Hi, my name is Joyce Cadorette, and I am discussing analysis of a healthcare informatics system for NUR 510 as part of the UMass Dartmouth MSN program. Informatics is pertinent to healthcare for many reasons. However, in 2006, the Agency for Healthcare Research and Quality, AHRQ, received a report from the Southern California Evidence-Based Practice Center stating that approximately 50% of the nation's healthcare costs were wasted on inefficient processes. Health informatics can assist with improving healthcare and reducing costs of healthcare as well. Informatics assists with the patient experience, improving health of populations, reducing per capita costs associated with healthcare, improving the functionality of electronic health records, improving information exchange that follows the patient, and analyzing trends of a population. Core competencies of healthcare professionals were defined by the Institute of Medicine in 2003. 5 competencies were identified. Those included delivering patient-centered care, working as part of interdisciplinary teams, practicing evidence-based medicine, focus on quality improvement, and the use of informatics. Healthcare informatics is an interdisciplinary professional specialty and scientific discipline that incorporates the health sciences, computer sciences, and information science, as well as other analytical sciences. The goal of healthcare informatics is to manage and communicate data, information, knowledge, and wisdom in the provision of healthcare delivery for individual patients, families, groups, and communities. Nursing informatics is a specialty that exists within the profession of nursing. It is a necessary contribution for the implementation of informatic technology in healthcare. Nursing informatics integrates nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice, education, research, and administration. Nurses have a role in evaluating technology while thinking about their own workflows to deliver optimal patient care and the impact of technology on patient outcomes. In order for informatics to be successful, nurses must be a part of the development of it, as they know their workflow and then they are able to translate it into practice. The healthcare system that I will be analyzing is a for-profit community hospital that is part of a larger hospital system with 36 community hospitals across the United States. The hospital originally went live with its first version of Meditech back in 2009. However, in September of 2018, they chose to launch an upgrade to a totally new platform from Meditech 6.0 to Meditech 6.1. My analysis will discuss the preparation to launch, the process of implementing the new platform, the benefits of launching the new platform, and the challenges of launching the platform, Meditech 6.1. The analysis will be specific to surgical services, as that was one of the main driving factors behind the upgrade of Meditech 6.0 to 6.1. In preparation to launch the new platform requires multidisciplinary and system-wide workflow. The surgical services team had a 2-hour conference call weekly. The conference call included leaders in surgical services from all hospitals system-wide participating in the upgrade. Representatives from Meditech were also on the call in order to be knowledgeable of specific requests and required documentation to be incorporated in the electronic health record. The initial go-live date for the community hospital being discussed was December 1st, 2018. However, the system moved the date up to September 1st, 2018. The date was moved up, and we were notified in July. Secondary to the short notice of the go-live date, education had to be implemented swiftly. Education, including in-person classes, computer-based training, and identification of super users. Super users were identified on each unit and available prior to the go-live date and during the initial weeks of the launch. The staff were also provided with test patients to practice documenting in 6.1, and the test version of Meditech was installed on all desktop computers on every unit. This way, nurses, if they had any downtime, could practice in Meditech 6.1 and become more adept with the skills required. Choosing the go-live date is an intentional decision by an organization. The September 1st, 2018 date was a Saturday of a holiday weekend, and one may wonder why you would choose this. A Saturday, a holiday weekend, staff on vacation, lower amount of resources in the organization. However, the choice of a Saturday on a holiday weekend was purposeful. Because it was the first of the month, the upgrade had a financial implication, and it was needed to start on the first of the month for billing purposes. The Big Bang approach was used because this would have the least impact on the hospital. There was no scheduled surgery, and all outpatient procedural areas were closed, and the impact to ambulatory services was minimally impacted within the organization. The Big Bang approach meant that all applications and modules were implemented at one time throughout the organization. In preparation for Go Live, the crossover from Meditech 6.0 to 6.1 was done on the weekend. Staff was incentivized to participate. So, for instance, in surgical services, we had to do what was called a cutover. Meditech 6.0 did not communicate with Meditech 6.1. Therefore, we had to print all the documentation that was done in 6.0 on all the pre-admission testing patients prior to the Go Live date. And on the Saturday of the holiday weekend, we had to implement Meditech 6.1 by manually entering all the documentation from 6.0 into 6.1. Nurses were offered an incentive to come in, leaders came in, and administration visited the unit while surgical services was doing this. Super users were present on each unit. Meditech support staff were available on all units. Each Meditech support member wore a green shirt, and they were easily identifiable to staff. There was additional Meditech support staff available to physicians during the Go Live period as well. There was a command center set up with both Meditech support, nurse informaticists from the hospital launching Meditech 6.1, and from other hospitals within the system who came to help. The command center held meetings twice daily, and staff leaders would bring back feedback from their staff to every meeting regarding documentation, order entry, whatever problems that they face would be delivered to the command center and would be acted upon immediately. In addition, staff and leaders could open up tickets through the IT help desk throughout the day. There were challenges during Go Live. It didn't all go smoothly. And some of the challenges including missing documentation. For instance, in surgical services, we use what's called the Aldretti post-anesthesia recovery score. There's one score for phase 1 recovery and one score for phase 2. During the Go Live period, it was identified that for some reason, the phase 2 discharge criteria never crossed over. So that had to be added into the documentation. So as you go through it, staff will notice things, leaders will notice things, and changes will need to be made. So it is very important to have expertise on hand that can fix any problem areas identified. Staff engagement. Staff was very challenged by the Go Live because the documentation was different. So therefore, we had to have tip sheets at each workstation that provided guidance to practitioners for the change in workflow. Super users would work with them. However, it takes time to memorize something. They've been practicing one way for many years in Meditech 6.0 with the documentation being one way, and in Meditech 6.1 the documentation was another way. So adequate support and resources needed to be available to make it successful. Physician compliance was a challenge. Prior to Meditech 6.1, physicians were still allowed to write orders on paper. The surgical chart has always been hybrid because not all the physicians are employed by the hospital. Therefore, patients' charts generate on paper in the office prior to pre-admission testing. So the physicians would often, even though we had mandatory CPOE compliance, still write their orders on paper. The throughput and efficiency in surgical services changed because the nurses were learning documentation. They weren't as swift and as quick at doing an admission and getting patient ready for surgery. So the turnover times from August to September increased. And in an OR, turnover time increase, minutes equal additional cases, which equal additional OR time, which equals additional revenue. So there was an impact on throughput and efficiency. And then maintaining patient and staff satisfaction. So the staff was instructed notify the patients as they were admitting them that they were working with the new computer system. And that although they were working with the new computer system and they were learning it, they weren't learning how to care for the patient. They knew how to do that. So their patient's care would remain the same throughout the transition as we went live. The goals of the upgrade included improvement of patient safety, increased meaningful use, which, as I said earlier, was to eliminate paper orders in surgical services and increase the use of CPOE, which has been shown to increase patient safety, decrease hospital length of stay, lower costs, improve quality of care, improve appropriateness of drug dosing, and decrease the amount of allergic reactions. There was also an incentive to capture some financial charges and incentives. Prior to go live in Meditech 6.0, now all anesthesia charges were being appropriately captured, and therefore the hospital was losing revenue. It is estimated that an average anesthesia can range from less than $500 for a local anesthetic in an office to $500 to $3,500 or more for regional anesthesia or general anesthesia administered in the OR. There was also an improvement of the patient accounting application. The patient accounting application tracks all charges incurred during hospitalization. For example, physician fees, medication fees, and procedural costs, including radiology, surgery, or whatever else is needed. And again, we capture the cost of anesthesia. We also capture the cost of recovery time, phase 1 and phase 2. In Meditech 6.0, because we had no tracking device of the amount of time patients spent in recovery, we were unable to charge for recovery, but now we can in Meditech 6.1. Supply cost capture, which is the acquisition, logistics, and management of materials in healthcare. Thus, a sophisticated information system is required to provide effective, efficient, and efficacious materials as needed. So, for instance, what we did in Meditech 6.1 is the physician slash surgeon preference cards were built into the program. Therefore, when the patient is in the OR nurse can charge for materials used immediately. In regards to implications for practice, there were several opportunities identified. The pre-admission testing chart today remains hybrid, paper and computerized. Again, this is because the physicians are not employed by the hospital and therefore use different computer systems within their office. The lack of interoperability between the hospital and physician practices makes PAT challenging. Interoperability ensures that electronic health records can exchange and integrate data. It is expected to improve quality and efficiency by reducing redundant care and improving care coordination through better frontline clinician access. This would be very pertinent in the pre-admission testing department, as anesthesia, the nurses in PAT would all be able to access patients' primary care records, cardiology records, etc., that could be pertinent to the day of surgery. As a workaround, we've reached out to these physician practices and asked for view-only access to other programs such as Athena, eClinical, and this way the nurses can access those records. But again, they need to print, and the chart is still hybrid with paper and electronics. Increased compliance with timely CPOE entry. This is very challenging in the PACU. Sometimes the patients come to the recovery room and the anesthesia provider has not yet entered post-op pain management orders. So that is a work in progress. And increased physician engagement. Successes include increased meaningful use, the idea of CPOE being used more frequently, safe and efficient patient care, potential for increased revenue, secondary to capturing revenue that was not captured in Meditech 6.0 as we talked about, such as the anesthesia charges, supply chain entry, etc., and potential for increased revenue secondary to supply management and charging. In conclusion, launching a new electronic health record or upgrade is a science. Careful planning must take place in order to minimally disrupt patient care and hospital operations. In the initial phases of Go Live, organizations must plan to provide close support to end users. As evidenced here, we had super users, we had Meditech support on standby, a command center, etc. Maintenance of the system is a continuous process which involves a variety of tasks such as application updates, patches for identified defects, and a continuous revision of the system in response to the user's request. And the final task of implementation is to determine whether or not the system made a difference based on the metrics identified in the pre-implementation phase. This task takes at least 3 to 6 months. So in the situation of this community hospital, the jury is still out. However, the data does appear that the goals of the upgrade have been achieved. Thank you.